السلام عليكم. I'm lecturer Dr. Hasanain Kahtan Al-Alwan, working at College of Dentistry, University of Baghdad. Today, I'm going to talk about the initial placement, adjustment, and servicing of the removable partial denture, which is abbreviated as RPD. After processing and curing of the flasked RPD, there will be a list of duties that should be checked, which are so important to follow in consecutive manner. These duties should be performed by the dentist or the prosthodontist to produce a biologically accepted prosthesis. At first, I'm going to show these in general, then describe everyone in detail. Number 1. Final inspection of the prosthesis before insertion. 2. Verifying the framework fit. 3. Assessment of acrylic resin denture base adaptation. 4. Assessment of peripheral extension of the denture base. 5. Evaluating occlusion. 6. Adjusting retentive clasp assembly. Last but not least, providing instructions for the patient how to use and care the prosthesis. Denture from the laboratory, and before making an insertion appointment for the patient, the dentist should inspect the processed RPD carefully. 1. For presence of any nodules or spicules of acrylic resin on the tissue surface of the prosthesis, where it can be located by running a finger over the intaglio surface, the tissue surface of the prosthesis. And removing with a small acrylic burr. Always keep in your mind, do not polish the intaglio surface. Check for presence of surface and internal porosity in the acrylic resin, which can negatively affect on the quality and strength and hygienic status of the completed RPD. Another point, you should examine denture teeth for any fractures that may have occurred during the processing or finishing procedures. Evaluate the denture tooth acrylic resin junction. If the junction of the denture tooth and acrylic resin denture base is improperly contoured, it will become a potential place for food entrapment and staining. Examine the acrylic resin metal framework junction. The junction should be a butt joint, 90 degree or less, with no overlap of the acrylic resin onto the metal framework. And finally, the finish and polish of the RPD should be checked. A properly finished, polished, removable partial denture generate a poorly finished polished removable partial denture generate a bad impression on your job and weaken the patient-dentist relationship. of the RPD. Notice the nodules and the spicules. This is the internal and surface porosity. You can notice the poorly finished framework acrylic resin junction. Look at the luster of well-finished and polished RPD. Before try-in appointment, the framework fit should be checked. Nevertheless, fit of metal framework should be checked at the insertion appointment. If there is a considerable resistance to seating, check the following. Number 1, distortion or bending of clasp assemblies or other components of the framework. 2, acrylic resin and the undercuts adjacent to the abutment teeth, which preventing seating of the prosthesis. And 3, a layer of acrylic resin flash may cover part of the metal framework. After the final inspection of the RPD and checking the framework fit, we should check the acrylic resin fit. This represents a primary consideration in the comfort and the acceptance of RPD. Excessive pressure may lead to discomfort, pain, and soft tissue damage. Apply pressure indicator paste evenly on the interior surface of the prosthesis with a stiff, short, coarse haired brush. A coarse brush will leave a specific stroke pattern as shown in this picture. That is displayed under pressure. The removable partial denture is then inserted firmly seated in a place where moderate contact has occurred. The brush stroke pattern will be indistinct or obliterated. Where heavy contact has occurred, the pink denture base material will clearly show through the white paste as the lower one. Pressure areas most commonly encountered in mandibular arch are: Number 1, the lingual slope of the mandibular ridge. In the premolar area. Number 2, the mylohyoid ridge. Number 3, the border extension into the retromalahyoid space. Number 4, the distobucal border near the ascending ramus and the external oblique ridge. While the pressure areas most commonly encountered in maxillary arch are: number 1, the inside of the buccal flange of the denture over the tuberosities. Number 2, the border of the denture lying at the malar prominence. Number 3, the point at the pterygomaxillary notch, where the denture may impinge on the pterygomandibular raphe or the hamulus. In addition, bony spicules or irregularities in the denture base that will require specific relief may be found in either arch. Assessment of denture base peripheral extensions. The peripheral borders of the denture base have a direct effect on retention, stability, and patient comfort. Both over and under extension of the peripheries can negatively impact the RPD. Denture base overextension may cause ulceration, pain, and the swelling of the vestibular tissues. Overextension may distract the abutment teeth through transmitting dislodging forces resulted from the overextension impinged muscles to the distal extension base, which transfer these negative forces to the abutments through the clasp assembly arms, where the longer distal extension, the longer lever arm, and the greater the potential for transmitting destructive forces to the supporting structures of the abutment teeth. Impingement on the muscles of mastication, such as the masseter muscle, may interfere with muscle function and during mastication and speech. So overextension may interfere with the speech. Number 3, denture border extensions of modifications spaces may interfere with the complete seating of the RPD. Inadequate distribution of masticatory force. That means inadequate support. In the lower denture base, it should cover the retromolar pads and buccal shelf area to the external oblique ridge to obtain maximal support for the RPD. Food impaction and the resulted annoyance and or an irritation. And 3, the prosthesis may lack stability, where underextended denture borders will not satisfactorily resist lateral or horizontal stresses. Acrylic resin denture base flanges should not be arbitrarily reduced. They should be critically adjusted only when physiologic limits have been exceeded. The buccal tissues should be held between the thumb and index fingers and moved apically, laterally, and then occlusally, Soft tissue movement adjacent to each denture flange should be noted. Restriction of soft tissue movement can lead to irritation. While mandibular lingual and distolingual flange lengths may be evaluated using physiologic movements of the tongue and the floor of the mouth. Clinical evaluation is accomplished by placing an index finger on the occlusal surfaces of the denture teeth on one side of the patient's mouth. The patient is then instructed to extend the tongue straight forward and then into the cheek on the opposite side of the mouth. If lingual or distolingual flanges are overextended, the denture base will lift away from the supporting tissues. This displacement is readily identified by the pressure against the operator's index finger. Can be placed on denture base flanges to help identify areas of overextension. The use of disclosing wax is especially effective on the distobucal border of the mandibular RPD, which is controlled by the masseter muscle. The most common areas of overextension of a maxillary RPD are the tissue side of the distobucal flange and continuing through the pterygomaxillary notch area. Contouring the anterior denture base flange. When designing a denture base for the anterior portion of the mouth, consideration must be given to the aesthetic requirements of the patient. Slight overextension or over-contouring of the labial flange may cause a successful prosthesis to be aesthetically failed. Moreover, an interference of the anterior flange could be observed during seating of RPD, that replacing an anterior missing teeth. The first step in anterior denture base adjustment is the application of pressure indicating paste to the intaglio surface of the resin. Correction of this interference involves vertical reduction of the flange periphery to the point of contact with the edentulous ridge. Following adjustment, the pressure indicator paste and the grinding residue are wiped from all denture surfaces and the fresh paste is applied. This procedure is repeated until the removable partial denture can be completely seated without encountering resistance, producing blanching of the soft tissues or causing patient discomfort. Of the removable partial denture following assessment of the RPD peripheries should involve only minor corrections by using articulating paper and show mounted burrs selected, which is called selective grinding, with a laboratory remount of the prosthesis before removal of the processed removable partial denture from the master cast. Otherwise, a new interocclusal record should be made. To remount removable partial dentures in an articulator, it is necessary to secure casts of both the dental arch restored by the removable partial denture and the opposing arch. The clinical remount is a more accurate method of adjusting occlusion using an RPD pickup impression method using the alginate hydrocolloid impression material, where the removable partial denture completely seated in the patient's mouth. Look at the picked up partial denture, removable partial denture inside the alginate impression, and this after pouring of the impression. The occlusion adjustment procedure, there are a specific criteria to be followed. It is better to consider one arch as an intact arch so that the other one can be adjusted according to the intact arch. If one partial denture is tooth supported and the other tissue supported, the tooth supported arch is first adjusted and is considered as intact arch for adjustment of the tissue supported denture. If both partial dentures are entirely tooth-borne, the one occluding with the most natural teeth is adjusted first and considered as the intact arch. If both dentures are tissue supported, the final adjustment of occlusion is usually done on the mandibular denture. In the practice of removable partial prosthodontics, two pliers are generally sufficient. These are the number 139 or bird beak plier, and the other one is the number 200 or called three-prong pliers. Procedure of clasp adjusting. Adjustment is performed by holding the clasp between the beaks of a number 139 plier and applying a bending force with the fingers of the opposite hand. While using number 200 plier, where the operator engages the clasp and gently squeeze the handles until the desired bend is achieved. Finally, instructions to the patient. Patients should be instructed and learned how to properly place and remove their RPD. The patient must accept the need for periodic dental evaluation, reviewing for the patient the proper brushing and flossing techniques for the remaining natural teeth. No use of any chlorine containing solutions. Removing the prosthesis before going to bed at night prevent denture stomatitis. Using of plaque disclosing tablets, that's very beneficial in educating the patient. Cleaned with the use of a small soft bristle brush. Debris may be effectively removed through the use of non-abrasive dentifrices. Household cleaners and toothpaste should not be used because they are too abrasive for use on acrylic resin surfaces. The patient should be advised to clean the denture over a basin partially filled with water to avoid any fracture during dropping. The patient should also be told to store the prosthesis in water when it is not in the oral cavity. Failure to do this may result in drying, cracking, or warpage of acrylic resin components.